Thank you very much, Mr. Chairman, and I would like to thank Professor Amgad and the organizing committee for allowing me to share with you this prestigious conference today. And the talk is going to be on COVID-19 and acute kidney diseases, what internists need to know. And the agenda is going to include clinical presentations of kidney involvement, concentrating on AKI, prevalence and outcome, pathogenesis of kidney involvement, pathological findings, management of COVID-19, AKI, and what internists need to know. So COVID-19 is really a very weird disease. Every time you think you have a grasp on the disease, then you find out that there's still a long way to go. It affects almost every system in the body, and it's very variable from mild self-limited disease to severe ARDS, multiple organ failure and mortality, and many lives have been just died from the period 2019 since the discovery of this disease in Wuhan, China. And even those survivors with mild initial cases can have a wide-ranging health issues for 6 months or more. So nephrologists have always been at the forefront for caring of these patients because of the commonly occurring renal manifestations, including acute kidney injury, glomerular disease with proteinuria and microhematuria, severe electrolyte derangements, and fluid imbalance. Now, about the prevalence, this is a very interesting systemic review and meta-analysis of 2,718 records where 59 studies, including more than 3,000 patients, reported an acute kidney injury, and 48 studies, including more than 27,000 patients, reported on kidney replacement therapy. And if you look at the pooled analysis of the patients admitted to the ICU, there were 46% developing AKI if you compare it to the overall pool prevalence of 28%, and 19% requiring renal replacement therapy if you compare it to 9% in the overall pool. So the conclusion is that AKI complicates the course. It's very common, occurring in 1 in 3 patients, and this is even increased in patients in ICU and with more requirement for dialysis. So the prevalence really varies in different studies, from 20 to 76% of patients admitted to the ICU, and renal replacement therapy 20 to 45% at a median of 15 days. And if you look at this study with 3,993 hospitalized patients with COVID, again you can see the proportion of AKI about 40 and 50%, and need for dialysis is around 20%, and mortality, and now we're speaking of outcomes, is almost 50%. And at discharge, you can see that only 65% recovering, and the rest of the patients are discharged with different stages of CKD, of acute kidney injury. There are many studies actually on the short-term outcomes, and this study here on 3,900 critically ill patients or admitted to the ICU, and data were collected from 67 hospitals, and this geographical distribution produces fair results with no bias. And again, you can see that 21% of patients developed AKI requiring dialysis, and 63% of those patients died in hospital, and 34% of survivors remain on renal replacement therapy at discharge. And the added conclusion is that COVID-19 is associated with a high inpatient mortality and persistent dependence among survivors at discharge. So this is the most recent on this subject. It was published in March 2022 on the kidney recovery and death, the outcomes of patients with COVID. It was carried out on 4,221 adults admitted to the ICU, collected from 68 US hospitals, so this is an ICU cohort, and 876% developed AKI necessitating dialysis, and this is the AKI renal replacement therapy subcohort. And if you look at the kidney outcomes, you can see that of those patients, 2,361 patients, which makes up to 56% of those patients, developed AKI. And there were different stages, of course. 12% were stage 1, meaning that you have around 1.5 to 2 times greater creatinine than the baseline, and 11% in stage 2, with some increase between 2 and 3 times the baseline, 12% in stage 3, more than 3 times the baseline, but still not necessitating dialysis, and 21% were on dialysis. And if you look at the outcomes in terms of death, if you look at the gray parts, you can see that the more severe AKI was associated with greater mortality. And also, dialysis on discharge, if you look at the orange part, in AKI requiring dialysis, it was 11%, and in the rest of the stages, it was only less than 0.5%. And if you take the sub-cohort on renal replacement therapy, you can see that the GFR below 60 mL per minute, day one of starting dialysis was associated with increased incidence of non-recovery, of course, and the lesser the GFR, the worse the prognosis, as well as the urine output at day one of starting dialysis. So when you have oliguria with less than 500 cc's per day, and when you have anuria with less than 50 cc's per day, this results in a worse prognosis for recovery. So the earlier dialysis, the better. And this study here speaks of risk factors, and it was carried out on 5,449 patients, and of them, almost 2,000 developed AKI, and that makes 37%, different stages, 1, 2, and 3. And this is the time of AKI diagnosis relative to the initiation of mechanical ventilation, which was very much close to mechanical ventilation as it's thought. And the conclusion was that AKI occurs early and in temporal association with the respiratory failure. The independent risk factors in this study were the older age, black race, hypertension, diabetes, cardiovascular disease, vasopressor use, and need for ventilation. But there are also other risk factors, including genetic risk, immunosuppressive state, smoking history, but above all, chronic kidney disease. And this study looked at this point of chronic kidney disease. It was done on more than 4,000 critically ill patients, and they included patients with pre-existing kidney disease. So you had dialysis-dependent, 143 patients, chronic kidney disease without dialysis, 521 patients, and the rest had no kidney disease. And if you look at the 28-day in hospital death, you will find that those with CKD, whether on dialysis or not, had an absolute death rate of 50% compared to 35% on those with no kidney disease. And the conclusion that those with pre-existing kidney disease was associated with higher risk of 28-day in hospital deaths. Well, now there are very few studies actually that look at the longer-term outcomes, and this study is a retrospective observational study in an expanded tertiary care intensive unit in London, and out of 313 patients, 240, which makes 76.7%, developed AKI within 14 days after ICU admission, and renal replacement therapy was initiated in 31.9%, so nothing new. But what's new is that they looked at the 3 months follow-up or mortality at 3 months compared to, and the AKI was 34% compared to 40% in non-AKI patients. And renal replacement therapy dialysis dependence was 4% at hospital discharge and 5% at 90 days. Renal recovery was unidentified in 81.6% of survivors at discharge and 90.9% at 90 days. At 3 months, 16% of all AKI survivors had chronic kidney disease, 44% in those without renal recovery. And if you look at the Kaplan-Meier survival estimates, you can see that with increasing stages, stage 3, the violet lines, you get more cumulative events and more number at risks. If you look here to the yellow and the green color, those are the patients with no AKI or had an AKI recovery. At 90 days, they are doing fine. Whereas if you look at those without recovery, they have an increase in serum creatinine that by 3 months, they still have some CKD because after 3 months, they thought to be chronic patients. And this is another study on the long-term outcomes follow-up for 6 months and 1 year. It's a retrospective observational studies and 53 critically ill patients requiring renal replacement therapy. And here you can see the estimated GFR at admission, at discharge, and at 6 months and at 1 year. And it was found that at admission, 22 patients had albuminuria and 29 patients had microhematuria. After 6 months, only 2 patients of the 14 survivors maintained these alterations. And surviving patients had decreased in estimated GFR about 31.7 plus minus 21.8 at 6 months and 29.8 plus minus 18.4 at 1 year, which is really significant. Survivor patients who developed AKI requiring renal replacement therapy in the ICU do not usually require long-term dialysis if they have normal baseline renal functions, but they need to post-discharge nephrologic care because they may develop later on chronic kidney disease, and Dr. Tariq has alluded to that. And this is the vast study yet on the long-term consequences in patients discharged from hospital. It was carried out in a total of 2,469 patients, 1,700 were enrolled. And it was shown that 6 months after symptom onset, most patients endorsed at least one symptom, particularly fatigue or muscle weakness, sleep difficulties, and anxiety or depression. So these are the long haulers or the long COVID, or they call it post-COVID syndrome. And more severely ill patients had increased risk of pulmonary diffusion abnormality as well. What about the long-term effects on the kidney? 6% of the patients in this study developed AKI during the acute stage. And the incidence of reduction in estimated GFR at 6 months, which is a CKD, it's a chronic disease now, reached to 13% among patients who did not develop acute kidney injury and had normal GFR during the acute phase. And this is the first time reporting affection of the kidney functions in patients 6 months after discharge who did not develop AKI and had normal estimated GFR at discharge. Of course, this is in comparison to 35% in patients with decline in estimated GFR. And therefore, severe COVID-19 requiring hospitalization, any disease COVID-19 requiring hospitalization should be an indication for kidney disease screening. Now, how the virus affects the kidney, of course, you know that it attaches to the angiotensin converting enzyme, and then the transmembrane protease serine helps the translocation of the virus to the attachment to the membrane and release of the RNA, which is going to result in upgrading of the profibrotic and pro-inflammatory cytokines. So as such, there could be a direct attack on the kidneys, causing glomerulopathy and tubular injury, but we can also have indirect effects like ARDS, producing kidney medullary hypoxia, inflammation with cytokine storm, hemodynamic instability with ischemic tubular injury, and individuals at risk of severe COVID-19 infections are those with CKD, whether they are on dialysis or not, as well as kidney transplant recipients. So for the direct viral invasion, SARS-CoV-2 can directly affect the renal tubular epithelium and podocytes. This is going to result in mitochondrial dysfunction, result in acute tubular necrosis and collapsing FSGS. And this is going to explain the presence of proteinuria in these patients. They can even affect the endothelial cells with endotheliitis. And this controversy remains as to whether SARS-CoV-2 infects the kidney directly or it's more with the indirect effects. And you have heard Professor Tariq speaking of lung-kidney crosstalk theory, with hypoxia causing alveolar damage and mechanical ventilation with threefold increase in the risk of AKI, positive pressure ventilation, reduction in cardiac output and renal blood flow and GFR with activation of the sympathetic and renin-angiotensin system, and higher tidal volumes are associated with higher level of pro-inflammatory cytokines. And what about the cytokine storm? And here you get a marked elevation of cytokines, especially interleukin-6, an increase in alveolar capillary permeability and pulmonary hemorrhage, which can lead to distant effects on the kidney. And when you have AKI, you get massive amount of interleukin-6 released from the kidney into the bloodstream, more than 100 folds compared to baseline. And CKD itself is associated with higher circulating interleukin-6 as a consequence of chronic inflammation, fluid overload, and reduced renal clearance. And even the therapeutic hemodialysis and peritoneal dialysis per se further stimulate inflammatory response and increase the interleukin-6 production. Hemodynamic instability, or let's say systemic effects, we can have other organ crosstalks like cardiomyopathy or viral myocarditis resulting in cardiorenal syndrome type 1, septic shock, endothelial damage, third space fluid loss and hypertension. We can also have tubular injury with nephrotoxins and rhabdomyolysis, hypervolemia with a positive fluid balance, and renal compartment syndrome. And please don't forget the hypercoagulability and microthrombi that were detected at TOPSI studies with DIC in small vessels thrombose and pulmonary infarctions. Now for the pathology, we can have light microscopy, immunofluorescence, electron microscopy, which can view the SARS-CoV-2 nuclear protein detection But again, aspects of virus-like particles have been strongly challenged because they may correspond to physiologic intracellular components such as class III-coated vesicles and multivesicular bodies. So the most commonly studied are the acute kidney injury and the collapsing focal glomerulosclerosis, which is the commonest in the GNs, in spite of the fact that glomerular lesions are rather reported in minority of patients, but you can also have thrombotic microangiopathy, which is rare, and other glomerular diseases. We're not sure if this is a de novo disease or due to unmasking of already existing disease. And hereby, I'd like to show you the results of the Path Lab case series of Professor Wissam Ismail, one of the very eminent pathologists, nephropathologists in Egypt. And this was from March 2020 till August 2021, a total of 100 renal biopsies from patients with COVID-19. 67 of them were native kidneys, and the spectrum of native biopsy findings were known COVID-related injury, post-COVID, COVID therapy-related injury, AKI on top of CKD, and unrelated or de novo renal disease. So it was found that 76% had glomerular diseases and 28% of those were with crescents. Acute tubular injury, 2 cases had pigment-caused myoglobin, and 2 other cases with oxalates, and ATI with light chain, 3 cases. And ATI on top of pre-existing disease were 5 cases. And the acute tubular interstitial nephritis, 3 cases. 1 showed prominent eosinophils, a renal infarction in 1 case with a history of DVT, a focal necrotizing GN with crescents, post-immune in 6 patients, immune complex mediated GN with crescents, 50% of them had ANA positive, and TMA, collapsing glomerulopathy, even iatrogenic phospholipidosis with history of COVID hydroxychloroquine prophylaxis. Lupus transformation was also present, and here you can see the podocytes, and you can see the virus particles even in the basement membrane with the spikes on the screen part. And here also are ultrastructure features of the kidney at postmortem, and here you can see the virus in proximal tubules as well as in distal tubules. And this is the immune staining of paraffin-embedded kidney tissue from patients with COVID-19. So finally, the treatment, actually there's no specific evidence suggests that COVID-19 AKI should be managed differently from other causes of AKI in the critically ill patients. However, the possible underlying disease mechanisms should be taken into account when considering approaches to the management of COVID-19 AKI throughout the disease course. So you have to take care of to prevent and manage multi-organ failure, individualized fluid management. Some patients present with dehydration, so you have to replace fluid in order to avoid AKI. And you should avoid fluid overload, consider dynamic hemodynamic monitoring, and monitor serum creatinine in urine output, correct hypoglycemia, consider alternatives to radiocontrast if possible without delaying urgent imaging, avoid nephrotoxic agents as possible, and consider AKI risk in selecting the ventilator strategy. Try to use lung-protected measures and maybe a little less PEEP in order to avoid the acute kidney injury, and consider renal replacement therapy, again, as like any other case of AKI, but earlier treatment is better, and prolonged kidney dialysis is better. Now, what internists need to know? In conclusion, kidney involvement in COVID-19 disease appears to be multifactorial. Clinical presentations include AKI, proteinuria, and microhematuria. Incidence of AKI is high, and even higher in the ICU, so as the renal replacement therapy. Mortality is high with AKI, so as dialysis dependence on discharge. The risk of mortality and dialysis dependence on discharge increases with more severe AKI, renal replacement therapy, and pre-existing kidney disease. And risk of CKD increases with renal non-recovery at discharge, and any severe COVID requiring hospitalization, even without ICU or AKI, should be considered, because those patients should be an indication for kidney disease screening. Please have a low threshold to consult the nephrologist, because earlier dialysis is better, and there's an urgent need for inclusion of patients with CKD in clinical trials, because many of those patients were denied treatment like remdesivir and tocilizumab, in spite of the fact that interleukin-6 antagonists, they can be used regardless of the GFR. And thank you very much for your attention.